Good evening, colleagues, and warm welcome to SWESEM Learning. This platform actually was created is to elevate the emergency medicine education throughout sessions that are not only informative, but intellectually challenging as well. So we made like a space where we refine the craft of the clinical thinking together. So my name is Mohammed AbuRagheef, and I'm an emergency physician specialist at the University of Uppsala. And tonight or this evening, I have this privilege to host a special webinar together with my fellows, Rasmus, Strandmark, and Malin Siebert. So tonight's session represents actually a very heart of the advanced emergency medicine, which is how we make decisions when the clarity is limited and when the risk is real and the time is very short. So diagnostic reasoning, cognitive error, and the evolving use of the Eclinical decision supporting tools in the emergency medicine that all of you have been reading through our advertisement. I would like all the time starting with a case just to refresh you guys. If you imagine that you're working in your ED and you suddenly hear about there is a 23 years old lady coming with a severe abdominal pain. And once you come into the room, you see that she is pale, uncomfortable, and she's screaming of the severe abdominal pain. Once you put her on the monitor, you see that she's a tachycardic and also she's a hypotensive. And what starts in your mind is the thinking process. Is this an ectopic pregnancy? Is this a bowel perforation? Is this an internal bleeding? Or this is maybe an ovarian torsion? What we have been reading of what we have been learning since the high school when we study math, that we have a problem, we identify the problem, then we're starting to solve it. As this what we have been also doing during the university and during our examinations. When you have a clinical cases, then you need to set a diagnosis in order to start the treatment. But this is the problem in the real life, that this is not applicable actually, because you need to work with both things together. You resuscitate the patient, you treat, and you find the diagnosis. I don't know how you searching for the diagnosis and wait till she became more unstable, or you will only resuscitate her and then find the diagnosis. We will keep our interactive session.
Oh yes, so yeah, look, this is a perfect lead-in to what we're talking about today, which is basically the an approach for emergency medicine that is different to other specialities, which is essentially it's a dynamic process that is not linear. Okay, so I will. Can you see my slides, by the way?
Yeah. You see
Okay,
that?
perfect.
Yes.
Good. Okay. Right. So should I take it away?
Or it's okay for you. Rasmus, do you want to say something?
Yes.
Yeah, just the quick thing that if you have any questions along the way here, just please put them in the chat and we'll try to just weave them in where appropriate. So feel free to interact in that way. Thanks.
Sure.
Bishan.
Okay, great. Well, thanks for that. Look, the overview of the talk we're doing today, and first of all, thank you very much. It's a privilege to be here with SWESEM. I've been to two talks before on this forum, and they're very high level technical information of emergency medicine. This talk, as Mohammed outlined, is really about an approach to emergency medicine. Something that was taught to me, which really helped me during my training, is how do you basically risk stratify patients, the importance of that, the importance of clinical diagnosis alongside that. And so more recently in sort of the latter part of my training was about the cognitive theory, fast thinking, slow thinking. And we're going to cover error as well. And clinical diagnosis is something that leads to a lot of error that is preventable compared to the system errors, which is what we're all dealing with. We're going to have some cases along the way. We'll start with some cases. Okay. So you've got to excuse my technical challenges because I've got this screen up at the moment. And just let me know. I've asked our panel to interrupt and check in with me so I know what's going on from their point of view. If I'm going too fast or it gets too boring, you just let me know. Okay. Hands up. or interject. So, look, my background is I'm a staff specialist based in New South Wales, but I've been in Sweden for the last 18 months doing a sabbatical. And the things I've been involved in here is digital health, and a lot of the work I'm doing is telehealth, which has given me an interest in the way we make decisions based on the limited information. Um, just to give you a bit of background, one of the things that we wanted to do with this session is also to have some international collaboration. I think the it's one of the things we find is no matter where we are in the world, emergency medicine has got some common themes. We've got some common challenges, as we find out in the conference circuit. And look, this is a hospital where I've been based, which is about 35,000 presentations, two resus beds. It's a mixed ED. We have like a focus on education. You've got a sim in the background, but it looks like very similar to the EDs that I have visited here in Sweden. I've been to Södersjukhuset, I've been in Uppsala, Sundsvall, and Umeå. Okay, great. So look, we'll just go with a quick case at the beginning. 49-year-old chest pain, severe 10 out of 10 central crushing pain. Only happened for about 30 minutes. No sweating or radiations, but a little bit short of breath during their presentation with the ambulance. Ambulance gave aspirin 300, GTN 300, and fentanyl, and the pain settled to about 3 out of 10. Within 20 minutes of arrival, the patient, so it's about an hour after the chest pain, wanting to go home. Now, we've seen scenarios like this. The person's got type 2 diabetes, hypertension, they're on metformin and an antihypertensive, nothing else. And he's a mechanic, ex-smoker, drinks alcohol. His vitals are normal, the VPG is unremarkable, and the troponins pending. Now, just keep that case in the back of your mind, along with, and this is the ECG, sorry. Keep that in the back of your mind, along with what Mohammed has given as a case, as a preempt. So does this patient need immediate resuscitation now that they're there? Are they needing immediate action? Are they likely to be admitted to hospital? Which specialty teams? What's your differentials? And what further tests, if any, are you going to get? Similarly, common elderly presentation, 78-year-old, anxiety, depression as a past medical, but reasonably pretty well, has fallen over, non-syncopal fall, the bloods are pending, the ECG is pending, and the wrist shows a fracture as shown there on the X-ray. Again, you can apply straight away what is the immediate actions that need to be happen. She's in a lot of pain. They're likely to be into hospital, or which specialty teams are likely to be involved. What is the diagnoses that you are entertaining, and what are the differentials? What further tests? So the EM approach, the mindset, really is about knowing how to do the immediate actions, as well as keeping in the background what is the direction of our actions and further investigations, as well as where we're going to end up. So which direction we're going without having to actually have the destination exactly there. So that is the acute management side of things. And the other thing,
we have saying on Thursday, just coming inside. I don't need.
I think we need to. I think someone's on needs to go on mute. Thanks.
Prime example of that. It was
Okay, so the other thing that they have is looking at a biopsychosocial and spiritual existential approach. The patient often presents with biological problems, but when we're looking at things like chest pain, psychosocial issues often are in the mix, and we're focusing a lot on the biological. So we have to keep that in a holistic mindset with our emergency approach, because we're dealing with sort of multiple factors that lead to these presentations. So the immediate side of things is really what do we need to do as a patient unwell? The things that need to be addressed immediately are pain, blood pressure, also if there's um, any bleeding, undetected trauma. Now, most of our algorithms that we do talk about resus, but we've got to think about the things that are often where patients are led to be languishing without getting appropriate starting of initial care for fluids, analgesia, and also getting the other teams involved for the team approach. Now, the second level is, are they in or out? Is one way of putting it. Are there people who can be managed within they need to be as an inpatient, or can they be managed within the emergency to the point where they get a stable discharge? And that is a decision as a senior you are always thinking because you're concerned about the flow of your department. The safety of the department depends on how much overcrowding there is, which leads to the errors. So this is an important factor. Which stream that we're going to be going to get involved. The classic is aortic dissection versus MI. They're different specialities, and they are going to involve different pathways. So it's important that we, as the emergency physician, the initial differentiator, get that. Similarly with abdo pain, someone having suprapubic pain from cystitis, or are they having diverticulitis, which is going to have completely different consequences on a medical ward as an admission versus a surgical ward. And then where, as Mohammed alluded to, when we were brought up as students in medicine, we were always taught to focus in a methodical way on the diagnosis. So a lot of the hold up in action for immediate and early treatment is this focus on diagnosis. But we in emergency are prioritizing risk assessment and starting the treatments. You've got someone who is hypotensive, they need IV access and fluids or blood, as our initial case suggested with the young woman who was hypotensive. So that is on one side of the equation. On the other side, we have that the diagnosis is actually very important because our direction of where we're going is the direction is set by the emergency department. And of course, we know that most of the information is in our history. The problem is we don't have time. So a rapid, broad history is essential. And this is how the investigations are done in parallel. So I guess one of the important things about the structured assessment, we've got our terms, is impression. Often I find that when we have people who are new to emergency, juniors may not want to commit to an impression, but and that does dictate which direction we're going on. I think like an anecdote that was taught to me was in emergency medicine, you're allowed to be wrong, but you're not allowed to be unsure. And that doesn't mean unsure about exactly what your diagnosis is. You have a differential, and I think it's clear to know this is what we're thinking, and these are the other things. It's like we said, are we operating on the potential for a ectopic pregnancy in the first case example, or are we looking at something else like an abdominal catastrophe, torsion? One of the things that we can do is there is a framework called QUID, which is looking at ways to improve clinical diagnosis. In emergency, we're often given the raw deal of limited information. Now, working right now in a world of telehealth, I've come to become more comfortable with less information, but still the collateral histories that I can get from the triage notes, the nurses, if sometimes if you've got elderly people, the nursing home, that is often a huge proportion of getting the diagnosis right. Focus also is on red flags, and I think part of the importance of like today's holistic view for the doctor is to understand the human factors. This is also a big factor in where we get error. Are we at the end of a series of, 4 or 5 night shifts? Are we tired? Is there something going on at home? So it's good to know what's going on with our how to improve our diagnosis in that way. And sometimes we might check more if we're in that situation. Communicating, collaborating across other teams and having shared decision. Um, so why is this stuff important? Well, I guess the reason I've always been interested in clinical diagnosis is because I'm interested in error. Why I'm interested in error? Because I've been the subject of near misses, misses, diagnostic error, as we all have. And I think one of the most satisfying areas of education in emergency is actually to help each other through that process. We're all here to be um, safer clinicians for the care of the patient, but also for ourselves, because diagnostic error, I mentioned at the beginning, a lot of my non-clinical portfolio is to do with doctor well-being and also to have a more humane system and people through error. One of the biggest things is to try not to make it in the first place. But the other side is safety too, which is looking at what are the things that we are doing well that lead to safer care in what has been termed as a laboratory for errors, the emergency department. So a lot of good work on this area has been done by Chris Hicks. You might have seen that there's a great emergency case podcast that I've put there, and I'm happy to share all these things. Brian Goldman has given a great talk about this, and essentially on his TED talk, he says the problem with the arena we're in is we have to be like elite athletes on our best performance every single shift, and we know that's not possible. So when we know we're not able to be that, we have to have safety nets and checks. The other thing is time is the greatest diagnostician, and we all know that's the one thing we don't have in emergency medicine. So I'm going to flick back to our panel because I can't. I'm actually going blind at the moment because of this screen sharing issue. So I can't read your faces. But how are we going so far, Malin?
But I think that now that you got the screen sharing working, we can see the text, and I think that it's going great actually.
Okay.
I don't have any questions in the chat, and well, I my take on your points as far as the first point when you um, value if it's very emergent or not. I have this score that I really like. It's called the looks like shit score. And if it's looked like shit, you
Love it.
need to act before you have more information. And that's pretty much it, actually. And
Good.
then,
Well, that's good. That's going to be a good lead into this next section because
yeah.
we're talking about fast thinking, slow thinking. So
I
look,
think
Yeah.
diagnostic
I
error.
I have a question
Mohammed
just
has
quickly.
some.
Yeah, exactly.
Yeah.
Thank you very much,
Sure.
Bishan, for your
Thanks.
approach. That you're starting like with a resuscitation or not, or is the patient is
Oh, here
stable
we go.
or
Here.
not. But my question for you is this: do you use this approach in your daily practice even with a stable patient, or only in the resus room when you have an unstable patient?
This is a great question because I use this for every single patient. Okay. And do I need to do something? So I'll give you a call and it could be in telehealth in real life. The last patient that I had was a category 2, was a near someone who was 28 weeks sorry, a 28-day-old pediatric patient. So a newborn, mother's worried because there was a vomit, and then they looked like they'd lost their consciousness a little bit or looked a little bit off. So that was triaged as a high category. But when I took the history going through, first thing I'm thinking, is this resus or not? Is this someone who needs to come into hospital, needs another check because they're a vulnerable population, they're a neonate. And they basically, from talking to the mother, she had had a appropriate concern, living by herself, not much social support. So when we go through the social history, that's an important factor for emergency. And essentially has had a period of 20 or 30 minutes after that completely settled, no red flags, eating and drinking. And I managed to do a capillary refill over the telephone, and also checked with, in the holistic sense, how do you feel about staying at home, or you want to come in? And so you can see quickly, dynamically, the history changed. Do we need immediate action or not? And then we're looking at what is it? Well, this case it'll be out and with a early GP review with a safety net. So you can use it like that. Now, the two cases that I mentioned at the beginning, that's a pretty standard case. An elderly person who falls over. Certainly, you wouldn't be thinking this is a resus bay patient, but you can still use that matrix because that allows you to think a bit more laterally. What are the things that are going to keep a simple distal radius fracture presentation or elderly patient with a distal radius fracture? Is it an isolated injury? Is there a syncopal component? Are there other things that led to the fall? So those are you're not really sure yet with that patient. So yeah, that's a longer version of that. This is for every patient.
Thanks.
So,
I also have a question here. If you don't want to follow up on that, Mohammed, if you
no, you carry on, please do.
No, I'm done. Thank you.
So Andreas raises a really important, obviously the maybe most important question in this talk, that what's your risk tolerance, what's for diagnostic errors in the ED? And I would like to sort of expand on that as well, because it's so many factors going into that simple question, right? And I mean, if you work in a rural area, you would inevitably have a higher risk tolerance because you don't have the tools available to you, or they're very far off. But then if you work in a university hospital setting, you have all these diagnostic tools close to you. You can consult colleagues and so forth. So your risk tolerance would be much lower. I don't know if you will probably touch on this later on in your talk here, but do you have any immediate comments on how to sort of manage your risk tolerance and what factors goes into that?
Yeah, well, that's a great question, Rasmus, and it's very pertinent. I think that the key thing that comes to mind when you ask about risk tolerance is safety. So we all want safety, and the important thing is you have to take enough risk within the safety for their patients. So the example that I just gave to you, that is that was quite a lot of risk. I mean, in a sense that I have to make sure that I have got enough confidence, and this comes into where we're going to lead into type 1. Type 1 thinking is also the heuristics of automatic thinking is this going to be good enough? For me, doing it as a clinician with 25 years experience as an emergency specialist, it will be quite different to what I would advise, say, a junior who hasn't seen as many cases, or if we have the resources that could pick up that patient quickly. Now, if you're remote, you're going to have a lower tolerance, and you're just going to, that essentially you're going to have a lower threshold for doing, a transfer. Okay. And if you're used to working in that environment, and you've seen these kind of patients come through, I think that you may develop a higher tolerance for that. But I think the key thing is, in terms of safety, sharing the risk load and having the safety checks will actually navigate a lack of tolerance or decreased tolerance, if that makes sense.
Yeah, it's certainly good for now, but I'll watch this point for Emre had an add-on question here, and Andrea's question is still sort of pending, but I think it's so many factors going into what risk tolerance you have. If it's an aortic dissection, obviously that's a very sort of lethal diagnosis to have, and your risk tolerance is maybe less. On the other hand, it's very difficult to initiate that workup, and then you have other injuries, maybe a fall in the elderly. Okay, can we actually mitigate the risk of sending those people home? how many are at risk because we're sending home so many. So there's so many factors that goes into this, and also where you're working and what the tradition is, maybe. But
Yeah,
I'm
and
sure
that's
we'll have the chance to get back to this.
okay. Well, good. And just one anecdote on that is one of the challenges we have is acute limb threatening, life threatening, like the aortic dissection is always a tricky one because we've got such a consequence for missing that. Our tolerance is going to be less for that because, and that's why we do end up doing so many scans when we have it available. Interestingly, in my position where I'm working in centers where they just you have to fly someone 2 hours away to get a CT scan, then you develop more tolerance for risk because you're looking at the resource limitations. So I always think the risk versus benefit, not just for the patient, but for the entire system. Of course, we're here for the patient. So that's another matrix that helps with that, if that helps. But we'll come back to that and we can bring it up again. So just thinking about diagnostic error, the one that we're really talking about, they've this Chris Hicks has gone into this quite a lot, and one of the schools of thoughts is that you have the area where there's no fault. Essentially, you know, we're operating where people don't tell us stuff, or sometimes you get patients that give misleading information, but that's a very small proportion. Most of the time, it's the Swiss cheese model, systemic errors, so multiple different factors, the holes lining up, and that's why our workplace is very important. To look at system-based errors and having mortality morbidity meetings, even talks like this on the agenda. So we think about it. Cognitive error. Now this is the thing, okay? It's actually on one side there's basic knowledge deficiencies that can be there, but most of the evidence points towards the way that we're thinking through things and biases that are actually causing the cognitive errors. Also, human factors, as we alluded to before, cognitive overload, those situational factors. So that's important to recognize because it doesn't matter how senior you are or how good you may think you are or how good you are. We all know medicine is humbling. So we know that these factors play to all of us, to the juniors as well as the seniors. Um, and then it's interesting that the one of the ways that we can improve our cognitive decision making is actually to understand what's going on. So let's go into that. What's going on with the quick diagnostic decisions, and also recognizing biases, which we'll do a quick overview. It's definitely not a comprehensive. So Daniel Kahneman got that Nobel Prize for Thinking Fast, Thinking Slow book, and it's got a lot of applicability. It's been translated into the medical context and also in a critical care context. And so, in essence, the type 1 or system 1, some people call it type 1, is the intuitive reflexive approach. And that has been likened to, if you're a Star Trekkie, you know, Captain Kirk, who basically pulls the starship out and sees and says we've got to get away from the baddies behind us. And then you've got the type 2, which is the analytical problem solving, which is, you know, what's it, Dr. Spock, who says, well, wait there, Jim. There's an asteroid field right in front of you. And many of us have been in this situation in the emergency department. We're just about to you know, give someone Clexane for a unstable angina or a someone who you got a high risk for non-STEMI, but then you're kind of thinking, hang on a sec, this could be a dissection. Do we really want to anticoagulate this person? Is this someone we're going to go through the scanner? Should we just hold off? You know, and so that analytical problem solving is about taking a step back and having this continuing self-questioning. And it takes a bit more effort, but most of the time we're operating as a senior level, we're operating on a reflective approach. And of course, the more senior, the more cases we've seen, the more accurate our type 1 is. So it's about stepping between these two things. And I think one of the keys is to recognize when you need to change when there's to a type 2 is when there's subtle inconsistencies. So we're always looking for these things that don't fit the pattern. And I think as a junior, you may find that it's frustrating when you talk to a consultant who tells you to do this, and you're like, this is simple. It's just that, you know, it's an easy pneumonia. You're like, oh, well, I don't know about this person's on, they've got immunocompromised, And I'm really worried about that, that skin lesion, like, is this an abscess? Like, what are they talking about? Because as a senior, you're seeing that there's some little voice that is speaking to you. Okay. Another word that comes up a lot in this cognitive decision making is heuristics, which are the shortcuts. And essentially, how an emergency doctor thinks is this typical? And if the answer is yes, like there's an illness script and you just go for it because we're processing, large volumes of patients, and we proceed to the confirmation of the diagnosis. If there's uncertainty, we can also go into another set of sort of shortcuts, which is rule out the worst case. Are they sick or they're not? And then there is the old shotgun where you think, you know what, this is a bit too hard. We're going to have to scan, get some more blood tests, and that is something when there's uncertainty. So that's a bit of how the mind works in the cognitive space. Now, beware of bias, and the common ones that are touted is recency or availability bias. If you've just seen a talk on PE, suddenly that diagnosis is everywhere, and it's just part of the human psyche. And then the other thing, which is a challenge, is the confirmation bias, where we look for evidence to support what we already think. And then, of course, the anchoring, which is you're looking at the initial features that have led you to a diagnosis. And there's a guy called Pat Cross-Carey, incredible body of work under his name, if you ever wanted to look into this more deeply. And one of the things is it's important when we talked about doing investigations, one of the things that can decrease bias is before you do tests, to always have an idea of why are you doing the test. This is what I tell all our residents, essentially, is to what do you hope to find? Why are you doing that? What's your pre-test probability? Even say that sometimes and play a game. Is it like, 70% chance you're getting positive, or are you doing it to rule it in, or are you trying to rule it out? So it's 20%, so you think that they've got a dissection, but you can't afford to miss that one, but you still know roughly how likely it is. So you have a pretest probability, then you have your test and a post-test. So that is also about having the diagnostic humility to think, and that allows you to avoid the anchoring bias as well, to get around that. It's because you are also acknowledging that it may be negative or it may be positive if you think it's negative. And so what about evidence-based medicine? Okay. Now, one of the best models I heard in training actually, and I've added a bubble in recent times, but it was told to me that you've got the evidence, then you've got to integrate that with the clinician's experience and background. I'll give you an example. I did research in Sri Lanka on organophosphorus poisoning. So I've seen like over 100 acute presentations of that condition. So the evidence is there for everyone. But if you've had a clinical experience, like I think one of the cases or one of the hospitals I visited in Sweden was people with hypothermia, which is, I think, in this winter season would play into something that you might not see in Central Australia as much. So the clinician's experience of the knowledge base and also the patient in front of you, the individual factors are actually also part of it. What do they want? Do they want, like our patient who wanted to go home? I mean, that plays into part. It influences you. But the other thing I find, which is really interesting, is local culture and practice, because I'm working across many hospitals at the moment, and I realize that in terms of teamwork and to incorporate evidence, there's no point using isolated evidence from North America in Iceland. What do you think, Rasmus, for example? Like, does it translate is the question, And I think local practice is also an important thing. That's why if you can get local evidence and local research to help translate what is already touted as being, good, nothing's absolute, then that's a helpful medium. And of course, I put in there with the evidence, which was the original title of this talk, which is to look at electronic clinical decision support. But I think we're going to put that into a different talk altogether and team up with with people who have been working in this field is a very interesting area, because that allows us to scout the evidence, the tools we have now, very quickly. In Australia, in like New South Wales, where I'm working, there's clinical decision support comes through knowledge funnels sometimes, so well accepted guidelines. We have something called therapeutic guidelines, so it allows people to translate evidence very quickly into acceptable practice. So, these are all things of how do we knowledge translate and practice evidence-based medicine. So before we go back to the cases, are we okay so far? I think we're running short on time, so let me know if you want to bring up anything, guys in the panel, anything in the chat. I can't see the chat.
No, we're certainly not going to bring the chat up because it will burst into this classical discussion about PEs, which always comes up, the diagnostic uncertainty. I will just put the lid on that for now. Yeah.
Thank you. Okay, look, let's go back to the cases, just because I think this is going to follow through with what Mohammed said. Is this for everyone? Every patient. So we had the patient who had this presentation. They want to go home. They're pain free. So we asked, what is our current impression, right? The troponins come back. They're 12. They're 13. That's within the normal limits. And he's got pain that is settled. Like, for the interest of time, without flicking it back, this looks like, I've had this case presented to me. He said, look, he wants to go home. I want to send him home. The drops are negative. I said, well, hang on, that ECG doesn't look quite right. What do you think about that T wave inversion? Does it, does it bring up any concern to you? Even without the actual syndrome knowledge, it has got some concern. You've got a red flag there. You've got a ischemic looking ECG. But we all know that that's the ECG of a Welland syndrome, and this person has basically, when we go back to our algorithm, he doesn't need any resuscitation at the moment, sure, but is he someone who could be safely managed in the community, or is he going to have a blocked coronary artery that's just about to clot off and give him a massive LAD, infarction? So look, we would be sharing the responsibility, care, and referring and advocating for admission for inpatient angio for this patient. And that the teams we know are quite straightforward in that particular patient. Now, we talked about the elderly fall, the bloods came back. The ECG is normal, chest X-ray, lung fields are clear. Notice that there's a sodium of 123, the creatinine is 180, and the CRP is slightly elevated. There's leuks and nitrates in the protein. So, I mean, this person now again still needs some immediate management. So we're already thinking about our diagnosis and our differentials. You've got someone who clearly has got a left wrist fracture. That's going to need to have pain management and reduction or stabilization, but they've also got a hyponatremia that's going to need medical input, as well as AKI and likely a renal source, or maybe even some pre-renal components. So the immediate management would involve the antibiotics, the admission, so the disposition is in for this person, and that's just one way of just looking at these patients from the outset to see, well, they may not be able to go home until we get some critical overview of what is going to allow them to be safely discharged with safety net. So this is actually interesting. A case I had in the presentation, very similar to the case that Mohammed pointed out at the beginning. You got a 29-year-old who is G2P1. She's 9 weeks pregnant. And she's had a 2-week history of vaginal bleeding, and been diagnosed as having an incomplete miscarriage by an outpatient scan seen by their general practitioner, she presented to the hospital because she'd had a initial scan that showed an intrauterine pregnancy, but the second showed no intrauterine pregnancy. So it looked like there's bleeding, and this is someone who's had a miscarriage or an incomplete miscarriage, and they're bleeding. So, but again, the principles are airway, breathing, circulation. Do they need resus or not? This person was having a pulse of 90, a blood pressure of 135 initially, but when they were assessed after they'd been sitting in the cubicle for about an hour. They looked unwell. They had a rapid respiratory rate, hypotensive with systolic of 90, and on examination tender. POCUS was done, and you see the familiar shadow, and in the with blood uh, tracking around at the hepatorenal angle and quite a significant amount. So again, we can ask those questions. They are for immediate management. They're definitely going to be in. Now, this is where we're thinking we've gone from someone who is, who is needing to have some sort of medical management as a potential outpatient to um, needing acute surgery. Gynecology is the specialty, and of course, we've got our diagnosis of ruptured ectopic, and that person actually was in a place where there was 20 minutes from a tertiary, so they had to get O negative blood on the way because it wasn't time for cross match, get them into an ambulance, tranexamic acid, and they ended up having 2.9 liters of blood in the abdomen. So we've seen these cases, but it's again showing the the point of the matrix. So the next one is another chest pain in a patient, 64, previous acute MI, with stents, woke up with typical pain, no radiations, of course, and they have had a sort of borderline blood pressure, 109/68. The point of care trop is elevated. They're a bit hyponatremic, but that's not the concern. We've already got the that unfortunately didn't project that well, but that is the actual ECG. But what you're seeing here is, I mean, and the question for our audience is, okay, you've already got the whole history together, and we're seeing inferior ST elevation, no reciprocal changes, but that is enough to make the diagnosis. And this was a peripheral center, so there wasn't a PCI. It was essentially done over remote care, telehealth, and with conjunction of local cardiology services with thrombolysis and transfer to a center that could do a rescue PCI. So this is a case, Mohammed might want to even back me up a little bit on this, because this is the value of these sort of international case discussions that happen about what is the sort of patient that you are seeing in your center. So I was having a chat once with Mohammed about this, and there was a 65-year-old patient with a background of hypertension, diabetes, and also had a history of VF arrest. They had a malignant VT as a diagnosis, and that's why a implantable defibrillator was done as a scheduled procedure 6 weeks prior. And they were actually just sent up from the cardiology outpatients because there was some chest pain, and they were in hospital. The nurse had taken some bloods. The blood pressure, the vitals were within stable limits, and the pain had settled. So it was a busy emergency evening shift, and there were other patients. I think there might have been a tox or a seizure going on in the background. So this patient was, as they are, left for a while. And the initial POCUS showed no evidence of pneumothorax or pericardial effusion. So again, what's our impression and what's our management, and it being the key thing, and do they need resus or not now? Well, they're pain-free. They have already got the defibrillator in. There's something that's going on so the first thing is no immediate management. But in terms of the in or out, well, this is a cardiac patient with significant comorbidities. There is definitely they're not in the out box yet. They're not going to be safely sent home, and there's some investigations that are happening. The first the troponins have already happened, and I guess part of it is to review. Now, this person later became unconscious, Threatened airway, SATs went down to 82, 60 over 40, the blood pressure, and you've got a POCUS as shown here. So suddenly we've escalated and trailed back into this immediate management recess. And of course, impression management now. How do we manage this? Well, in the interests of time, the differentials that clearly on the cards was, is it a tamponade? Is it someone who has had a dissection that's sort of bleeding back into the pericardium, or was it an MI with a ventricular rupture? You know, likely tamponade, and also probably because of the instrumentation. So that person also got the appropriate management and was had an increase in level of consciousness, responsive to treatment. So going back to that repeated examination gives us that information when we don't have the time, we have the delta, the change in status. So I think that was a rapid overview, hopefully trying to impress the universality of our core business, how it goes across the range of patients from pediatrics to obstetrics and gynecology. We talked about cardiac and also elderly geriatric patients, where essentially we're presented with a story of here's a problem, this is something, should I fix it? Or a holistic view of what is the thing that needs to be done now? How do we exercise that? Either resuscitation versus acute management. Are they going to be safe to go home? Because one thing that was once told to me early on in emergency medicine is, what's the easiest way to kill a patient? And that is to send home someone who really needs to be in. But if we admit every single patient, we're doing them a disservice and our hospitals a disservice. So that is the caveat. That number two of, are they safe for a safe discharge, or do we need to keep on to do what we need to do in hospital? And then sending the people to the right stream is avoiding error, and the cognitive biases of the path that we put our patients on is important. So look, I'm going to flick back now to our panel, and hopefully that has been of some value. Like I said, it's not a high-powered talk, it's more a nuts and bolts.
No, I mean, it certainly raises a lot of questions. It's like, oh, what about this case? And how the other way? What would Bishan think of that? And, so I'm just going to hand you one of those cases now, because it laces back to Andrea's questions as well. What's our risk tolerance? And it's so highly sort of, it's not static, is it? It's affected every single day on our mood, whether or not we're working a night shift, and the last type of patient, and even hearsay, as in this case. So I was handed over a gentleman. He was around 30, 35, and he come in with scrotal pain that started yesterday evening. It was over the night shift, so he hadn't had his ultrasound or anything like that. They've done some bloods and urine. There wasn't much to see, and the examination was quite unremarkable. So they thought this is an epididymitis. And instead of sending the patient home with a very mild presentation, they ordered this ultrasound that I was waiting for them. And I asked why. If this patient presents to the primary care, they'll be sent home on ibuprofen. Listen, there was this other case where we had a formal ultrasound of an epididymitis, sent that patient home, and it turned out to be a torsion. Okay, wow. So you want a formal ultrasound on this patient due to that and for that reason. And obviously coming out of night shift, she wasn't really able to explain her line of thought or anything. But it's interesting, could have happened to me as well. So I'm not sort of saying anything about my colleagues' reasoning. It's just the way that we humans act. We sort of have this fear of making the wrong decision, and in this case, maybe also medical legal things to think about. Do you have any sort of reflections on how to mitigate that? Because obviously this led to a bit of extra weight for that patient and an unnecessary examination.
Yeah, look, I'm sorry, the internet cut out for a little bit of it, but the gist of what I heard was there was a concern about the you did that to look at epididymitis, and what did the ultrasound show? I missed that.
The ultrasound was unremarkable. We couldn't really even say that it
Mm.
was a clear epididymitis, but it was done
Mm.
to sort of have legally show that you've actually done an ultrasound to rule out torsion, more or less.
Yeah. Like, I mean, look, for us, definitely in our setting, we definitely, if we, and it's funny you should mention this thing about torsion, because this has come up in a meeting, in a group of colleagues about this, and there is a differential level of consciousness. It has been said that, the only people who are going to basically differentiate out torsion are the urologists, because they're the ones making the call to do the procedure, right? I've been a urology regent in a former life as well, and I know that you don't, ultrasounds, it could be intermittent torsion, and so really it's a clinical thing, isn't it? So I guess, and I had the similar case where I thought, look, the story does not tick the box for me to transfer this patient to get a surgical review where there's going to have a junior surgical doctor who's going to try and make a call anyway. I think there's enough to not transfer this patient, and they can get an ultrasound. Because normally I wouldn't be doing an ultrasound if I'm really suspecting a torsion, right? But these gray zone patients are the tricky ones, right? I mean, if it's a barn door classic. So I think the answer to all of this is what was put in that presentation, which essentially I was taking it from Chris Hicks' work, is to have a greater awareness of the biases, because it's not solvable, right? We can only mitigate risk, and I think part of it is about the risk tolerance in your group. So my personal practice has always been to find out when are the mortality morbidity meetings for whatever group I'm in, and really have an active role in that, and to encourage that we have these review processes. So we want to know when are we having near misses every single month. We need to know what are the near misses, and then we talk amongst our group. What would you do? Would you be are you happy with that? Because I am. And what I think, just in relation to the initial question, which is a really good one, risk tolerance, there's such a variation in risk tolerance, and I think that's acceptable, because that could be based on your own condition, your own clinical experience of the condition at hand, which is what I said in that slide about the evidence-based medicine. So essentially, your own personal experiences as emergency physicians vary between emergency physicians. And so I think just talking about it and checking in is one of the ways to decrease the consequences of risk tolerance, and to get a feel for it. There's a question from Mezzi, I think,
I think,
from
yeah, we
Canada.
could, as if you want to unmute and
Could we squeeze that in, or
yeah, I think so.
yeah? Oh, Mezzi, go for it. Not sure if you're trying to speak. We can't hear you. Oh, here we go. Off.
Can you hear me?
Yeah.
Yes.
Cheers. Thanks so much. Thanks, Bruce. Thanks for a wonderful presentation. I really enjoyed it thoroughly, and it kind of speaks to how my practice is going on recently. I'm sort of struggling these days because, as you know, we work together in Australia, and prior to that, I worked in the UK, and I'm currently in Canada. And my risk assessment, tolerance, and diagnosis have been pretty much everywhere. And sort of like to what Rasmus said early on, risk tolerance and its assessment is very geographical, and I kind of find that to some extent, is also quite societal, with strong cohort differentiations, pre-hospital versus in hospital. And I think with the virtual space that we both kind of work together, it kind of creates a whole new dimension to what risk tolerance assessment is. Because you can argue that a dog bite in Sydney is very different from a dog bite in Lagos. Two different risks, two different populations, two different possibilities. And I also kind of think that with diagnostic reasoning, in my recent experience, it's very complementary with the resource that's available. For example, when I moved from England to Australia, my CT scanning went up tenfold, easily tenfold. In fact, I probably scanned more people in one day than I scanned 1 week at the Royal London in England, which is for me was very shocking. And then when I compare my time in the Outback to when I was working in Wollongong, south of Sydney, it was another tenfold difference. And currently now in Vancouver and BC, it's gone up another tenfold. Like you wouldn't have a headache or a dizziness in an all the while well patient without having a CT scan. Neuro wouldn't even discuss it. They wouldn't discuss any neurological issue, however benign, without a CT scan, and obviously 24 hours MRI scan. ENT would not even take a phone call for a clear-cut Bell's palsy without a CT scan. So it's I kind of keep changing hats all the time, trying to remind myself where I am and what the risks and diagnostics are to kind of deliver patients good care. Because what I used to think was good practice doesn't quite obtain, and I guess just what we're saying, it really differs on where you are and how the practice there and what patients expect. So patients expect certain things to be done also, and I think that has to be factored in 2025. I was kind of wondering how do you in your own practice, how do you reconcile these variations, you might say?
Well, that's a great question, a great reflection as an international experience. And I'm going to make it short because essentially it was that Venn diagram that I showed. The way I do it is I think that I like to be someone who is a evidence-based sort of knowledge translator, but also a humanitarian. So that takes into the account, the patient in front of me, not just blindly following their wishes, right? Because my job is then to educate, to bring the health literacy up so that we know that we actually don't want to be doing harm to these patients. We don't want to be doing a CT scan on a 20-year-old person and irradiating them for a headache just because it's local culture and practice. Because you kind of just highlighted that new bubble that I put into that diagram very well, because local practice and culture it really influences how we practice. And I think all of this is a predominantly Swedish society, and I'm sure the Swedish trainees who are listening will know if they've worked in different centers. Things are done slightly differently because that's been our experience in Australia, New Zealand, and you have reflected in UK and Canada. And Rasmus, would you say also in Iceland or
I can't get my head around Iceland really, sort of, because I'm not sure what's going on in Sweden. That is my reference point, but we're certainly sort of doing a lot of safety medicine here, a bit more than I would like. But yeah, so it's certainly trending towards that, which is unfortunate.
So it's interesting just to reflect about safety medicine. And I know how are we going for time? Can I just finish off this bit, or are we going to wrap up? Because what I did suggest is if people wanted to stay on, I'm happy to, but I know Rasmus has to go, and we should probably wrap it up, I think, at the moment, and then we can stay on for those who want to chat further. What do you reckon?
That sounds like a great idea. I mean,
Sure.
personal thank you to everyone that participated here, and I'll leave the word to Mohammed and Malin to finish up once you wrap up. Keep it going. Great to see you.
Very good. Bye.
Thank you, Rasmus. And for those of you that are able and willing to stay on, let's continue discussion. You were saying, Bishan.
Yes. No. So I think in answer to Mezzi's question, essentially it's a bit of a rhetorical question because we don't really have an answer to this, but it's a common challenge that we're all facing, and to the point where I found it really fascinating just the prelim conversation that Mohammed and I were having before doing this talk, and I didn't realize that the fear of missing things in Sweden is leading to over investigation in a big way. Because I thought that Sweden isn't a place that you couldn't get sued here, or it's not a big law-based place. And certainly practicing in New Zealand, I knew there was a huge difference because in New Zealand we have a system called the health. It's called ACC. So doctors can't get sued. The government compensates. So it has a whole different thing, and it affects people the way that people practice. So I noticed a big difference going to Australia. Just recently, so I didn't realize that this is a fact, and I'll flick back to you, Mohammed, and to recount our conversation. But it's really interesting because just in the chat today for our telehealth group, someone had taken a picture of an advertisement from lawyers that was said basically, have you had a medical, have you suffered at the hands of a doctor? Well, look, we're here to help you. Basically saying we're going to sue them for you and we'll do it free of charge. And I saw those ads 20 plus years ago in America. So that was a big part of their sort of investigation culture. And I remember those 20 years ago, I was a surgical reg at that time, and we used to, make calls on appendicitis based clinically. Back then, we didn't have so much access to CT scans, but the Americans at the same time were like, no way. So some of it, you could argue has made practice more safe, that we're accountable, and that's great. But the pendulum has definitely swung in some countries way more. And this is reflecting back to Mezzi's comment. I would like to just continue the discussion. Ask you, Mohammed, how do you see this in your practice, or Malin, you know?
Well, I have just a question, or maybe directed to you, because if I'm looking at your approach, it's starting to minimize the things. And is it really applicable for an intern or residents? While we want them, to be more open-minded, to think out of the box, and to think of many differential diagnoses. How do you translate this? It's very difficult. Like for a consultant, maybe I can use this approach. But for a trainee or resident, I think it will be very difficult.
This is actually an interesting thing, because what you got to do is there's got to be governance. So one of the issues that we're having is who has the authority to order all these scans. So in Sweden, can a first year doctor order a CT scan, for example?
That depends on the clinic, but yeah, in general, yes, they can, and they do, and there's less consequences when you over investigate than if you missed something historically and like structurally. But I think that that is one of the main and core changes that are available in reach with the emergency medicine as an own specialty. I think that the differential, when you have to think and decide which of the possible diagnosis am I okay missing, rather than what could I possibly find on this patient, and like
Yes.
adapting to what is really meaningful. And I think that is, it's very easy to uh, order a whole series of troponins in every patient that is obese and over 50 years old. And the skill is to know when you don't even need the first one, and when you actually need to keep them, even if they want to go home. And yeah, I think that that is requiring experience, and that's when.
So this is to be honest, that is one of the core business sort of elements of being an emergency physician as a senior, so a staff specialist, and having a department, because part of the thing is to create a set of audit and policies to reinforce the good evidence. Now that Rasmus is gone, we can open the lid without going there too deeply on the whole. Let's not talk about PE, but let's talk about D dimer. Do you know what I mean? So,
Yeah.
and so we have a good I mean, one of the things that has been a game changer was the PERC rule. Do you guys use the PERC rule, PERC rule?
Yes. Yeah.
Yeah, so that's a game changer because how many juniors want to just maybe do a D-dimer, and that gives you a great evidence-based opt-out that can safely say we don't have to do this because then we're going to commit to a whole series. It's called the conveyor belt of investigation. Then you're
Mm-hmm.
going to get these things called incidentalomas. And you've
Yeah.
suddenly done harm to patients just by finding out things that never mattered. And I guess the thing about this is so the best way I say is just using the principles of the talk is if we have an idea of pre-test probability, right? So, I mean, flicking back to the cases that Mezzi talked about from Canada, I mean, the pretest probability of seeing something in, like a 20-year-old with some sort of cluster headache or whatever, atypical migraine usually, right, is from getting a CT scan, your pretest probability is going to be very low, but you're influenced by local practice and patient expectation. Again, this is all back to that slide on, I wonder if I could pick it up on evidence-based medicine. And I guess if we increase the awareness, so what we do is having emergency departments is say, look, we have a knowledge of the type of patients who come to us, which are the undifferentiated patients going to differentiated. The physicians or the internal medicine doctors have a different perspective. They want to know things like, vitamin D levels. Like when I did general medicine, internal medicine, they wanted vitamin D levels. I said, I've never ordered that before. Like, does it change your management? Well, that's the question, they'll say. It depends on what school of thought you come from. So, and that's fine because, every specialty is good at what they're doing. But for us, we can't use that mindset because it's not going to bring joy to helping do what we're doing, which is to differentiate patients, provide acute care, and get them in the right direction. So, yeah, look, that's my thoughts on it, but I'm going to zip it because I've been talking a lot lately. See what else is out there.
Yeah, well, and I realized that I might not be finishing my thought earlier on the first year residence. And I think that we also accept that juniors make more investigations and take more time with the patient, which also is some sort of investigation. And that's fine at some point and level, but like that we're starting to get some frames on how much older investigation is okay. And I think that's to come back to, I don't know who it was that was talking about to remind oneself of where am I and why am I here, and that it differs if you work at the ER or if you work as a doctor in the private section when they pay for this so that they can be sure that they are not having a problem with their knee. And in the ER, well, if you don't have a problem in your knee, we won't bother with the knee. And well, it's good to remind oneself, I think. And some over investigation is okay, as it is that some errors in what we are missing is okay. And the skill part is to choose which ones we will miss and which ones we will over investigate.
Yes. Well, look, I mean, just to reflect back, there's another thing that's going on. There's a lot of groups that are, again, going about knowledge funnels. So there is the whole choosing wisely movement. The UK were quite big on that. I don't know if that has influenced things here. So there was a lot of talk because there is a whole movement to something called low value care, high value care. So we're trying to get away from low value care, which is a lot of what we're talking about, isn't it? Low value care, which has so many implications. So in terms of choosing wisely, there's a whole bunch of researchers who came up with these algorithms who are keen on trying to at least provide the low-hanging fruit, the easy things, like the perk rule for people who come in with any tiny bit of niggly pain and they're 20 or something, and at least that's another set we have to go to. But I agree. To reflect back what you said, there is the patient in front of you, Malin, and there is this thing called always listen to the voice inside. And that is that's your system one, and it can be wrong, but then at the end of the day, it is telling you something. So I think there's a balance, right? So I agree. I think you've got to we can't be too sort of sure or one way in emergency medicine, because we're basically swimming in the ocean of uncertainty, but we've got a boat that gives us structure. So that's the thing. And I say, when I'm doing something that is a little bit over investigating, I'm able to justify it, and I will use those criteria in the history, like the red flags. Oh, thanks.
Yeah, I really like that as well. And sometimes when I know, I don't have the time, it's crowded, and I know that this is probably an over investigation, I will tell myself, well, today, Malin, it's okay that you take a CT scan of the head when you think that it's probably not bleeding. You will do it to make yourself free of this thought. And I think that's fine as well. Now we have something in the chat. It's people that have to go. They're very sorry, but they also have lives as well.
No, that's good. And I think just one thing is, it's nice to know whether this was a bit of an experiment, but it'll be interesting to know from the people. They can feedback on their the Facebook what they think about the discussion element. I think that's good. I think we should wrap it up then. What do you reckon, Mohammed?
Yeah, it will be fine. Exactly. Because now we made it like a new thing, interactive sessions, not only webinars that you just only sit and write. So sometimes it's very good just to express yourself, because we are colleagues. So it's very good, like, to know each other. So it's very good. I think we do it like sometimes.
Wonderful. Well, it's been a great pleasure to be here, and I feel honored and privileged. So thank you, everyone. And take care. Peace out. Keep doing the thing and patting yourself on the back. See ya.
Sure. Thank you very much, Bishan.
Thank you, Bishan.
Thank you so much, everyone, for the audience, for the moderators.
Yeah, thanks, audience.
And see you next time.
Yes, Anna. Thanks. Bye.
Bye.
See ya, Mohammed.
Bye.